Environmental emergencies. We only focus on two, heat and cold related illnesses. 2196. All right, let's start with heat-induced illness. So we just came off of the hottest year of the planet. Okay, 2024 was regarded as the hottest year on record.
No, we've had hotter than that.
We have heat stroke and heat exhaustion. Let's start with heat exhaustion first. Heat exhaustion is simply dehydration because of extreme heat. Now, heat can be environmental heat, or it can also be exertional induced. Let's say you run a marathon, for instance, or you jog under the summer sun. Okay, so that's obviously you're prone to heat exhaustion. Okay, simply by dehydration caused by heat. In that instance, if you're running in the summer, then that's a double whammy because you have exertional heat, right? You're producing heat from muscle contractions, plus the environment is very hot. So that's a double whammy right there. So you'll have heat exhaustion. Or let's say we have a marathon at the during a heat wave, for instance, then you could suffer a heat stroke. Heat stroke is now an acute medical emergency because unlike heat exhaustion, wherein your mental status is relatively well. You can drink fluids, you can drink hard water, Gatorade or any other sports drink, for instance, to replenish lost fluids and electrolytes. Here in heat stroke, the temperature is so high because the patient's heat loss mechanisms. How do we lose heat again? Radiation, how else? Conduction, evaporation, by sweating, for instance. Okay, so these are how our body loses heat, correct? These mechanisms fail when we suffer a heat stroke because now, unlike fever, wherein the patient's thermostat change, correct? Meaning, if you have a fever, that means you have an infection, you have a pyrogen somewhere in your body that's causing your thermostat to change, right? The set point rose. So let's say our set point is supposed to be, let's just put it at 97 degrees Fahrenheit. So when you have an infection, then the set point changes to, let's say, 101, 102. So now the body struggles to meet the new set point. So set point, think of it as a thermostat. So if you set the thermostat in your house at 78 degrees, for instance, same thing in our body. So normally our thermostat is at 97, right? 97 degrees. So the body, of course, tries to, whenever we run or if it's too hot, the body adjusts, right? We need to meet the thermostat setting, which is 97. So if it gets too hot, then we start sweating, we start panting, right? So we start taking off our clothes, okay, dress lighter. So these are the heat loss mechanisms. Here in an infection, when you have a fever, the thermostat changed to about 102, 103 or higher. So of course the body will try to meet that temperature, right? So that's why we take antibiotics or we take Tylenol to bring the thermostat back down. Now, here in heat stroke, the thermostat did not change. This thermostat remained at 97. However, because of the extreme heat, extreme dehydration, now the patient is unable to the patient's heat loss mechanisms start to fail. So you no longer sweat, although we do have a few heat stroke patients that still have sweat, but generally speaking, when the patient is in heat stroke, there's no more sweating. You lose the ability to sweat. You cannot therefore get rid of the heat. So that could be dangerous because what will happen to your brain at, let's say, you reach a temperature of 107, 108 degrees? That's enough to fry your brain. So that's why the patients with heat stroke, number one manifestation is mental status changes. Okay? They become delirious. They no longer, when they have heat stroke, they're now have bizarre behavior. Okay, so now can they get out of the sun? No, they'll stay out in the sun because they don't know what to do anymore. Okay, they're so confused, so that will make condition worse. Prevention is best rather than management. Of course, this is totally preventable. If you have elderly friends, neighbors, or relatives, then please check on them whenever it's hot outside in the summer. Then later we'll do the same in cold related conditions as well. So here avoid um, too much exposure. Okay, so the planet is warming, so we need to be more aware of this. Okay, stay hydrated, for instance. Replace water loss. Okay, so the more you sweat, then the more you should be concerned about replacing that fluid. Okay, so it's best to bring sugar drinks like Gatorade, for instance, okay, those rich in electrolytes so that you're replacing both hypotonic and hypertonic fluid loss. And be aware of cooling measures. Okay, so what have you guys been doing at home? What besides the AC? What well, not everybody can afford, the high bills. So what have you guys been doing? Okay, showers or those moist towels, right? To cool yourself down. Um, everybody's been wearing these Gore-Tex type clothings now, right? So, the those that wick moisture wicking, garments, the air cooled garments, from Uniqlo or other brands. Yeah, so those are getting popular, yeah, because they're cooler. If you have to plan anything outside, then avoid between 10 a.m. and 2 p.m. That's the hottest time of the day. So plan things before 10 o'clock or after 2 p.m. If you have to, let's say some people, by the nature of their work, let's say you're a utility worker, for instance, you have no choice. You have to be outside. Yeah. So just be aware of your break times. Okay. Everybody's in a union now. Okay. So union um, policies allow you those breaks now, especially if temperature outside reaches a certain point. So you're allowed a number of mandatory breaks. Be aware of chronic illnesses because they make matters worse. So your compensatory mechanisms may be failing. Okay, if let's say you have a heart disease or a lung problem, diabetic, or you have a kidney disorder, for instance, these are the very organs that we use to compensate, correct? So just be aware if you have or your family members have those types of illnesses. Look at the temperature. When we assess the patient, it reaches 105 or higher. What's the highest temperature you've ever had when you were sick? 102, right? 103, yeah. I mentioned, right? When I was a baby, I was sickly. Yeah, so my temperatures usually reach 103, 104, and then I have a seizure after that, and then crap myself. So with heat exhaustion, we have dehydration manifestations. I won't repeat that. We finished already fluid electrolytes as well as hypovolemic shock. So same manifestations, but this time it's caused by heat. Okay. And with heat stroke again, same manifestations because all heat stroke patients underwent heat exhaustion first before they developed heat stroke. Management. First thing, of course, is to cool the patient down. So most of the time, this is when we have heat stroke patient, heat exhaustion patients, it's always outside, correct? Or if it's, let's say, we have a heat wave, then that's the exception. Patient may have no AC. Let's say our elderly grandparents, maybe they have no AC because they're on a fixed income. Okay, so they're trying to save money. They're in the house. It's sweltering hot inside the house. Okay, so those would be exceptions that they're indoors, but most heat stroke patients are outside. So our interventions are the following. So first priority is to cool the patient down. So if they're outside, what do? Do you treat them right there under the sun? Okay, bring them to the shade. Okay, or if you can't do that, then put the shade over there. All right. So that's the first thing you do. So take off wet clothing and then apply ice to these following parts of the body, because these are the, how do you describe the neck, groin, chest, underarms? They have plenty of arteries, right? There's plenty of blood vessels, so you put them there. So we will cool the patient internally fast. We put cooling blankets if you have them. Otherwise, just put cold towels on the patient. Immersion of the patient in cold water bath. This is easier if the patient is a child, but if an adult, then we may have to just do ice all over the body, ice packs. You can add others because using ice is only what? Conduction, correct? So we can use other methods as well. Convection, they use fans. How else? Radiation, that's why you take off the clothes. Okay, so let heat evaporate in the body and radiate at the same time. The internal cooling measures are not mentioned here because this is only the highest temperature here is under 107 degrees. So there's no need to really institute internal cooling measures. So external cooling measures are enough to bring the temperature down. Does that make sense? Okay. So for exertional heat, heat stroke and heat exhaustion, we stop the active cooling measures once the temperature reaches 100.4. At this point, the body can take care of itself, right? So because we don't want to induce hypothermia either. Are we clear? So we'll have a different cutoff point later when we get to malignant hypothermia or temperatures reaching 111 degrees. It's a different rule. Monitor the patient for arrhythmias. This patient underwent extreme dehydration, so there's tachycardia here and electrolyte losses as well. So there might be some arrhythmias. So in the hospital, they'll be put on a cardiac monitor. And apply oxygen. This will help increase perfusion. Remember, they're dehydrated, right? So there's hypoperfusion as well.
So what's the last thing? You said something.
Cardiac.
Something in perfume.
Oh yeah, perfusion.
Yeah, but what's again? No, I know, but you said something with perfume.
Yeah, per organ. Oh, okay. Okay, IV fluids are necessary. Remember, heat stroke has heat exhaustion as well. And because the patient, can they go into AKI? What type? Pre, intra, or post-renal? Pre-renal AKI. So put in a Foley to monitor kidney function. During the aggressive cooling, because we put the patient on ice, right? So we don't want to trigger shivering either. So that will be counterproductive because once they shiver, then they produce heat again. So we may administer benzos. I usually give them lorazepam, Ativan. And once fully awake, then we can give the patient oral fluids when they don't have the mental status deterioration anymore. And if they survive, tell them not to do it again. Yes, Jennifer? To prevent shivering. All right, next. Let's go to cold. Before we go to cold, let's finish the hot first. So there's one more heat-related injury here. Under chapter 15. It's one of the complications of anesthesia. Okay, this won't take long. It's probably just 15 minutes. Okay. Malignant hyperthermia. So this is a rare inherited muscle disorder. So because it's inherited, that means genetic, right? So passed down from generation to generation. Now it's rare. So probably there's one of us that has the trait or has the gene in this classroom, maybe only one. We don't know. We don't really screen everybody. It's not cost effective. So let me describe the disorder. So you have, let's call it the malignant hypothermia gene. You develop the disorder if you're exposed to general anesthetic drugs, and one drug in particular, which is a muscle relaxant or muscle paralyzer. The drugs that are known to trigger are the following: halothane, enflurane, isoflurane, and succinylcholine. Halothane, enflurane, and isoflurane are general anesthetics. These are gas medications. Have you ever had general anesthesia for anything? What did you have? What surgery was it? Tonsillectomy?
No, I had a couple orthopedic surgeries.
Oh, okay. So you were given the gas. They told to count backwards, and then that was it, right? You're
I
out.
tried so hard, 9%.
Okay. So succinylcholine is a muscle paralyzer. So it's also frequently used. So most of the time you'll see all three. Okay. So you'll see given either halothane and succinylcholine or something else, right? But among the frequently used medications for surgery, these are the following that are known to trigger the reaction. All right, let's develop a scenario. So let's say I have the gene. Because it's a reaction to general anesthesia, can this be prevented? 100%. Well, I shouldn't say 100% because what if I don't know my parents' history, right? Okay, so majority of the time, this can be prevented by simply asking the patient certain questions during the pre-op period. Okay. So another concern here is what if it's an emergency surgery? Right, so we don't know the patient's history. We can't ask because it's an emergency. So that would be, of course, one of the few instances that this may be happening or this may be triggered, unintentionally. But if let's say it's a routine procedure, we had time to do proper pre-op. So all you do is when you get to the anesthesia questionnaire, the first question that pops up on Epic is, do you or did you or any family member receive general anesthesia? When you say yes, then another question pops up. Did you or a family member have a reaction to the anesthesia? If the answer is yes, then that tells the anesthesiologist or the nurse anesthetist to not use halothane, enflurane, isoflurane, and succinylcholine because we don't care what that reaction is because all we need to know is the patient had a reaction. We don't need to know what that is. It's good if they knew, but most of the time, if a patient suffers or suffered malignant hyperthermia, it automatically goes into the medical record and the patient isn't even aware. If they survive, they're not even aware that it happened. Okay, because we took care of it. But we make sure it never happens again by what will we do? We put these drugs on the allergy. Okay, so the patient is automatically allergic to these medications. Does that make sense? Okay, because we don't want that happening again. Okay, because you were lucky that you survived it. So moving forward, so now again, all we can prevent this by simply asking, completing the the anesthesia questionnaire. So if there's a yes answer on they received an anesthesia, and especially the part where they said they had a reaction, then we avoid these drugs. Okay, we use something else because there are other anesthetics, there are other muscle relaxants available for use. However, since these are the most cost effective, what do you think ORs will use? These drugs. Okay, they're cheaper, so we will use these drugs commonly. Plus, are there a lot of people that have this condition? No, it's rare. It's very rare. How rare is it? If you work in the hospital and you know somebody who works in the OR, ask them about their experience with malignant hypothermia. I guarantee they'll say, "What is that?" They know about it, but they've never even heard of it happening. There's a kit in the OR because it's required by Joint Commission, but that kit expires, they renew it, expires, renew it. Okay, that's how rare this thing is. But it's good to have the kit if this happens, correct? Okay, again, it's required by Joint Commission. So what actually happens? So let's say you have the gene, right? Okay, so you go into the OR. The reaction can happen anytime. Can happen right there during anesthesia induction. As soon as you were exposed to one of these drugs, then you have the reaction. Sometimes, though, it's a delayed reaction. It may happen right in the middle of surgery, or it can also happen toward the end or a few hours after surgery. Okay, so there's acute onset, there's a later onset, and then there's delayed onset as well. So when do you think would be the best time for this to happen? Before, during, or after surgery? I would rather it happen before because I haven't been cut yet, so we can attend to the reaction. Worst thing is in the middle of the surgery. We have all your guts out. Okay, you have a big incision, and now you have this reaction. Maybe you can appreciate it. So yeah, but let's look at the what happens. Okay, other triggers besides these drugs are the following medications. So epinephrine, atropine. So this will be other drugs that may intensify the reaction. All right, so what exactly happens is here. So let's say I'm the patient. I have the gene. You gave me the mask for anesthesia. So I breathe it, then I'm out. The earliest manifestation is tachycardia. Unexplained tachycardia. I haven't been even cut yet. We understand there will be some tachycardia once I have an incision, right? Because of course I'm injured and I'm starting to lose blood, so of course that will trigger sympathetic response, right? So there'll be some increase in heart rate. However, this one is unexplained. And then further, on top of the tachycardia, the patient will also have an increase in end-tidal CO2, which is strange because the patient here, after we give you general anesthetic, we intubate you, okay? Because once you were given the general anesthetic, you will be given succinylcholine to paralyze you. And then we will intubate you, and then you'll be placed on a ventilator, mechanical ventilator. And that ventilator, of course, is ventilating you regularly, giving you oxygen, giving you a set number of breaths. It's in control of your breathing. So there's really no reason for your oxygen level to drop and therefore your CO2 levels to drop. I mean to increase. So the what therefore is the reason for the tachycardia? It's actually the drop in oxygen. Okay, so where did the oxygen go when you're on a ventilator? all the oxygen in your body went to the muscles, because once you're exposed to these drugs again, every single muscle in your body will start to contract. It's a non-stop contraction, meaning think of from your head, from your scalp, all the way to your toes. Every muscle in your body will contract. So what will each muscle that contracts consume? Oxygen. A little or a lot? A lot, because we're talking about your entire body here, which are contracting. Every single muscle, your eyelids, everything, your fingers, everything will contract. And therefore, each muscle cells that contract consume a lot of oxygen, dropping your oxygen level, increasing CO2, and what happens automatically to the heart rate? Increases. And what is generated by each muscle contraction? When you're at the gym, what are you generating? Heat, right? Okay. So the hyperthermia here is actually a late sign. The temperature can exceed 107. It can even reach 111 degrees Fahrenheit. So that's enough to cook your brain. This will cause brain damage. All right. So do you want to see early or late signs? I want to see early. What are the two earliest signs again? Unexplained tachycardia and hypoxemia and or hypercapnia. That means low oxygen, high CO2. Those are your earliest manifestations, followed, of course, by the extreme muscle rigidity. So rigidity from your jaw, everything. So if you lift this patient's arm, it will stay up. You lift this patient's leg up, it will stay up. That's how rigid the muscles become. And that, of course, will raise temperature. Again, the rise in temperature is a late sign. So do we wait until the temperature gets to 104, 105? No, we start cooling, okay? But the first action, of course, is what? So once we see the reaction, let's say the anesthesiologist, or let's say it's you that noticed it. You're the circulating nurse, and then you saw, why is the temperature, why is the heart rate going up so fast? And look at the end-tidal CO2. It's rising. So what do? If possible, they have to terminate the surgery. If possible. Okay, so if, let's say, that's why I said the best time for this to happen is before surgery, because we haven't cut the patient yet. So if it occurs there, great. We can't proceed with the surgery. Our interventions will be the following. So again, stop the surgery if possible. If not, what can we do? So let me describe what will happen to the patient, and then you can decide what interventions will be done. Okay. So the moment your muscles start contracting, so the oxygen levels drop, right? CO2 levels rise, so heart rate increases. So what will be intervention for that? Oxygen will be number one. So of course, stop if possible. Stop the delivery of the anesthetic and the succinylcholine. Replace it. If let's say we're in the middle, we need to give anesthesia, right? So replace it. We change the drug. So besides oxygen, what else? Because the muscles will start to die, correct? Because they will contract nonstop. So you need to replace the succinylcholine. The drug approved for malignant hyperthermia, the other muscle relaxant is dantrolene sodium. So this is in that malignant hyperthermia kit. So this drug, this vial is there. So you're going to give it IV. So this will help stop the reaction. Okay, this is the only FDA approved drug used to stop malignant hyperthermia. In the meantime, there's already muscle injury, correct? So is there already myoglobin in the blood? Will this now start damaging the kidneys? Okay, and so can this cause AKI? Pre, intra, or post? Intrarenal AKI. Meanwhile, every dead cell, regardless if it's a muscle cell or whatever, what will every dead cell spill into the bloodstream? Potassium. So now we have hyperkalemia as well. So how do we treat hyperkalemia again? What are the interventions? This is severe hyperkalemic, so not K-oxalate. K-oxalate won't be an option here. Plus, this is an emergency. So what do we give? It has to be complete. Regular insulin with dextrose. Okay, you can't say dextrose. Insulin. No. Regular insulin with dextrose. What else? Calcium gluconate. What else? Bicarbonate. Okay. What else? Albuterol. All right. So these are your emergency treatment for hyperkalemia. How do we know the patient's phase of AKI? Whether they're in oliguric or diuretic. How do we know? How do we know how much the urine output is? We put a Foley. Okay. Patient needs a Foley. Monitor hourly urine output. No, because if it's a short surgery, it's not necessary. All right, so that's your management. Now, or that's your initial management. Now, as far as cooling the patient, let's say the patient's temperature is now rising, 105, 107. Now we do internal cooling measures. We still do external, we put ice on the patient, but we need to cool them inside as well. So the IV fluids that we will give, LR or NS, will be wrapped in ice. We need to cool the IV solutions. Okay, so we'll simply wrap the bag in ice and then we'll start infusing cold IV solutions. We will also, if possible, we can put an NG tube and then lavage the patient's stomach. We put ice water into the patient's stomach. And the Foley that we insert, if possible, that will be a 3-way Foley. That way we can irrigate the bladder also with ice saline. And then we will also put a rectal tube and put cold water into the rectum. You understand what we're doing? We're cooling the patient inside and out. Because how else do you drop? Temperature's 111. Okay, you have to drop that temperature if you expect to save this patient's life, right? Otherwise, they'll go into, if they survive, they're in permanent brain damage already. Okay, that heat is devastating to brain function. Okay, so you cool them rapidly. So in this particular scenario, since the temperature is so high, we stop the cooling measure at 102. Unlike in heat stroke, when did we stop at heat stroke? 100.4. This one we stop at 102 because this is internal cooling. So we stop the internal cooling at 102. So since this is an emergency, do we do oral temperature or axillary temperature? Rectal. Okay, so we need core body temperature. So the temperature probe will be inside the patient's rectum. Okay, that's how we monitor. Then when do we stop the internal cooling measures again? 102. We hit 102, stop the internal cooling, and then we'll continue with just the external. And hopefully this patient survives. Then we'll never do it again. Okay, so we mark the patient's chart. Allergic to what? Succinylcholine, halothane, enflurane, isoflurane. Other textbook actually has a longer list, probably 3 or 4 drugs more. Your textbook only mentions these 4, so
test this only.
yeah, the trigger. Okay. Keep in mind there are drugs that will exacerbate or worsen it, and these are the drugs that will worsen the reaction or intensify the reaction. All right. Any questions on malignant hyperthermia? Okay.